Hello and welcome to another Critical Caring lecture. Today we're going to speak about PF ratio. Now PF ratio is something that we do daily, routinely on our ventilated patients, and when people join our ICU as residents or as rotational residents, they always tend to ask that one, why do we do PF ratio on every patient and repeatedly? Two, what does PF ratio really tell us? So this will be the things that we will be discussing in this lecture. So PF ratio usually has a forward slash between the P and F. Well, it basically is an abbreviation for PaO2 forward slash FiO2 ratio. It's also known as the Carico index. So PF ratio, how do we calculate it? Well, it's pretty easy. The name itself is the equation or the formula that we use. It's P divided by F, that is PaO2 divided by FiO2, and this gives us the PF ratio. So where do we get the PaO2 from? This comes from the ABGs of your patient. So the ABGs will tell you what the PaO2 of that patient is, whereas the FiO2, this value is going to come from, if the patient is ventilated, it's going to come from mechanical ventilation. If the patient is on room air, he's going to be on 21% oxygen anyway, and you'll know that. And if the patient is on an oxygen source, that is, if the patient is, for example, on a Venturi mask, it is going to tell you how much the FiO2 the patient is receiving. So the oxygen source will determine what the FiO2 is of that patient currently. It's not so easy just to go ahead and mention 21%, as it is fractional inspired oxygen, FiO2. It has to be expressed as a fraction. So if the patient is on room air, that is 21%. So if you want to change it into FiO2, you have to divide the 21 by 100, and you will get 0.21. So this is the FiO2 that the patient is receiving. In the same way, if somebody is receiving 55%, you know that the patient has an FiO2 of 0.55, whereas this is the oxygen percentage that we tend to use most of the time in our routine day-to-day life. So when you divide the PaO2 by the fractional inspired oxygen, you get the PF ratio. I tell my juniors that the easiest PF ratio to measure is when your patient is on 100% oxygen. That is, the patient is on 1 FiO2. So when the patient is on 100% oxygen or 1 FiO2, the PaO2 is the PF ratio. You don't even have to calculate it, because PaO2 divided by 1 is PaO2, and that is the PF ratio. So the easiest way to calculate PF ratio is when the patient is receiving 100% oxygen or 1 FiO2. That gives you the answer straight away by just knowing the PaO2. So why do we do PF ratio in our patients, and why do we do it repeatedly? That I'll show you on the next slide. So why do we do PF ratio? So PF ratio helps us in assessing hypoxemic respiratory failure. It helps us in diagnosing diseases like ARDS, and plus it does help us in monitoring our patients who are in respiratory failure. If the PF ratio is improving, then this means our treatment is maybe working. And if the PF ratio is decreasing, then we really do have to question whether our treatment is working or not. So PF ratio does have a role in both assessing, diagnosing, and monitoring our respiratory failure patients. So when our patients do have uh, bad lungs or have hypoxemic respiratory failure, looking at PaO2 sometimes alone can be misleading. I'll show an example as how this can be misleading. Is that if a patient has a PaO2 of 40 on an FiO2 of 0.21, so we know that the patient has a bad lung because he has a poor FiO2, poor PaO2 at room air. So if the same patient has supplemental oxygen increased to around 40%, which is a 0.4 FiO2, and his PaO2 bumps up to 80 millimeters mercury. So if we don't look at the FiO2, just looking at the PaO2 can be very misleading, because the improvement in the PaO2 can misguide us and maybe make us believe that our patient has improved over the course. So by just looking at PaO2, we see that the patient has improved, but when we look at this picture by keeping in mind what has happened to the FiO2, PaO2 has improved, but his FiO2 has also increased. This means his oxygen requirement has gone up, which is a bad thing. So that's why if we do a PF ratio, now this patient has a PF ratio of around 200, which is just at the limits of moderate ARDS. So this patient, although his PaO2 has improved, if you check the patient's PF ratio is still 200. So although if the PO2 has improved, the increase in FiO2 shows us that the patient is still at the borderline of moderate ARDS. So this is where PF ratio helps us in knowing better than just looking at PO2 alone that our patient essentially has not improved over this course of time, whereas looking at the PO2, he has. So PF ratio gives us a better view of the patient's underlying lung state than just looking at PO2 alone. So that's one way that PF ratio does help us. So the main disease that we diagnose with the help of PF ratio is ARDS. Although we have other diagnostic criteria to meet, but I think discussing them would be out of the scope of this lecture, but PF ratio is one of them. And in 2012 came the Berlin definition, which made things a bit more easier and simple. So a PF ratio of 300 to 500 is usually thought to be acceptable, or should I say normal. But a PF ratio of 200 to 300 was labeled in the Berlin definition as mild ARDS, and between 100 to 200 was labeled as moderate ARDS, and less than 100 was severe ARDS. This was before all this Berlin definition came out. 200, 300 was labeled as acute lung injury, whereas all this range was labeled as ARDS. So this was the old definition, and this is where the new definition came in. It made things easier, that anything less than 300 is ARDS. There's just a spectrum of mild, moderate, and severe. So this is one of the main ways we use PF ratio in our patients, is to diagnose or to uh, gauge and stratify ARDS. Now, one thing I would like to mention here is that the PF ratio is dependent on a few things, and one of them is barometric pressure. Most of the readings and most of the research that is done on PF ratio is usually done at sea level. So a person standing at sea level will have a normal of 300 to maybe 500 PF ratio, whereas the same person, when he goes up a mountain to a higher altitude, his PF ratio will drop because the atmospheric pressure drops as well. And if the same person was to maybe go to a valley, his normal PF ratio would be most probably more than 500, because the atmospheric pressure has gone up. So we need to keep in mind and do consider these atmospheric pressures. I would say, at least if you um, live at a higher altitude, um, or in the mountains or in the hills, you need to consider this as well. But I think in major cities, there are most of the major cities are more or less at the sea level. But I cannot comment on where you would want to use this. But if you are at a higher altitude, barometric pressures will play a part. In the same way, the other thing that the PF ratio is very dependent on is PEEP. And again, this is something which um, is again very misleading if you want to monitor your patient's improvement, because as we discussed earlier, the Berlin definition had very discrete PF ratios for mild, moderate, and severe ARDS, and all of these PF ratios, 200 to 300, and then 100 to 200, and less than 100. So all of these PF ratios were specifically done and measured at a peak of 5. So once a patient is diagnosed as ARDS, one of the first things that goes up is PEEP along with FiO2. FiO2 is a part of the equation, so we're not worried about that. But unfortunately, PEEP is not the part of the equation when it comes to PF ratio. So if the PEEP goes up, the equation itself cannot sense that. And for example, a patient who had a PF ratio of 200 had a PEEP of let me get this on to a newer slide. Think of it this way, that if a patient has a PF ratio of 200 on a PEEP of 5, so I would want his PF ratio to be more than uh, at least more than 300. So I have two choices: either I go up with FiO2 or I go up with the PEEP. So if I use PEEP and I increase the PEEP up to 8, his PF ratio might come up to maybe 300. So if he comes up to 300, and if I just look at PF ratio, I would say that the patient has improved. But in reality, we have just seen the improvement because we have increased the PEEP. So the patient can more or less maybe the same, and the patient might not have improved, but the PF ratio might mislead us by showing us, yes, our patient is improving, whereas his PEEP has gone up, which is a bad thing. So um, all these PF ratio values work best. Although you can do PF ratios at a certain PEEP and then monitor how he responds on while staying on that PEEP, maybe 8 or 10, or but it becomes difficult to compare PF ratio at a PEEP of 5 to a PF ratio at a PEEP of 8, because then you cannot per se be sure about what made the PF ratio be better, or what improved the PF ratio. Was it the disease subsiding, or was it the increase in PEEP? So I would suggest that when you do your PF ratios initially, always try to get them at a PEEP of 5 uh, to diagnose ARDS according to the Berlin definition. But if the PEEP does increase, maybe to 8 or maybe to 10 centimeters of water, uh, the, for as long as the patient does stay on that PEEP, for example, if the patient does stay on a PEEP of 10, you can compare the PF ratios while, like for example, the PF ratio was 200, then it became 210, maybe it became 190, maybe it became 250, and maybe the patient improved and it became 310. So as long as the PEEP was same in all these readings, you can compare them. But if the PEEP is changing, um, it's difficult to compare PF ratio at a PEEP of 10 to a PF ratio at a PEEP of 5. So that's one thing that a lot of people tend to forget, and might label the patient as improving without considering that the PEEP has increased as well. Um, and this is one thing that the PF ratio has to be standardized according to PEEP, and this is something that is missed out many a times in clinical practice. Now, what does PF ratio tell us about? What does the PF ratio tell us about? So we know that PF ratio deals with hypoxemic respiratory failure, and so it should tell us about how well the oxygen from the air that the patient has inspired travels down or diffuses into the capillary. So this is a very easy way to say that it tells us about how well the oxygen travels from the capillary from the alveolus into the capillary. But there's more than meets the eye that's going on over here. So oxygen has to travel through first surfactant. So if I blow this up over here, so we have the alveolus, and we have the capillary. So this is just the magnification of the same area. So this is the area where everything related to gas exchange takes place. So the patient, when he inspires, we have FiO2 in the lungs. So we have FiO2 over here. So that's the oxygen that the patient has inspired. The first thing it travels through is the layer on top, which is the surfactant. The second is the respiratory epithelium. The third is the basement membrane of the respiratory epithelium. The fourth is the area in between, which is the supportive tissue with collagen and everything, and that's the matrix. Then comes the basement membrane of the endothelium. Then is the endothelium itself, and then comes the RBC, where the oxygen has to go inside and combine with hemoglobin to form oxyhemoglobin. So it has to pass through the lipid bilayer. So it's the lipid bilayer of RBC. So all this is happening just to get the oxygen from the alveolus to the capillary. So gas exchange happens at this area. So when oxygen crosses into the capillary, the first thing it touches is plasma, and in plasma oxygen exists as PaO2, and when it crosses the lipid bilayer and combines with hemoglobin, it becomes the SaO2. So both of these values are present in ABGs. So why we use PaO2 and why not SaO2 to tell us about the gas exchange? So the example I give to people is that just think of a place with a wall, and this wall has a door in it. So if I want to know the condition of this wall, if I want to know the information about this wall, so I have people standing here, I have some people standing over here. On both sides, and I have a few people sitting in a bus traveling near the wall. So if I want to know the information about this wall, the people who will give me the best information about this wall are the people who are standing beside it. So on the side of the lung we have FiO2. So these people are the FiO2, and on the other side of the wall in the capillary we have PaO2, whereas the people who have already sat in the bus are SaO2. So the best two, and these people could be the air outside. So the best people to tell me the condition about this wall and how well the people are going in will be FiO2 and PaO2, thus the PF ratio. So next time when you see a number like a PF ratio of 100, a PF ratio of 200, a PF ratio of 300, or a PF ratio of more than 300, Don't just think of it as a number according to the Berlin definition. Of course, we have to label it as mild, moderate, severe, or uh, acceptable, normal, but think of it as something going wrong with these 6 layers. The seventh is not a part of PF ratio. Something is happening with these 6 layers. So think of it as an initial information that something is wrong at the alveolar gas exchange membrane level. So once you start thinking about that, these numbers will slowly not matter, but the meaning behind it is going to matter. And whenever you see your patient going from 200 to 300, an image will start to form in your mind that things are improving in this area. And if a patient worsens and goes from 300 to 100 PF ratio, you will start to imagine that yes, something is going on over here. Maybe there's edema, maybe there's maybe there's a collapsed alveolus. Maybe we have pus in the alveolus, or maybe there's a consolidation. Maybe there's some effusion that's putting pressure on the lungs. So we can go on and on. So things like this will start coming into your mind. So the number is only to make you start thinking about what's happening in this region. So I hope this uh, presentation about PF ratio helped you guys. Feel free to comment down below and let me know if you would like something else in this video. I can always update the video, and do let me know if I missed out something, or if there was a mistake that you want me to correct. Please let me know. I'm all open for comments, and um, I'll see you next time in my next lecture. Thank you for watching. Please subscribe to my channel and click the bell icon for latest video updates.